So while they are sitting down, I would like to say a few words for those of you who are not familiar with development cooperation and international cooperation, just to set the scene. It has been now something like 25 years that we discuss about the issue of aid effectiveness, and the aid effectiveness agenda has been has materialized through notably the idea of setting up sectoral approaches, later on through the Paris Declaration on aid effectiveness, and more recently the International Health Partnership. Another issue that needs to be taken into account is the need to strengthen the ownership and the autonomy of local communities. And this is notably one of the main points of the Declaration of Dakar on health districts. Those issues of aid effectiveness and development cooperation are really important today because of the increasing fragmentation of and complexity of global health sectors. So in 2015, it was the term of the Millennium Development Goals, and now the scene is characterized by the priority given to sustainable development goals, and especially universal health coverage, which is really the #1 priority for global health actors in the field of health system strengthening. This is notably the case through the UHC 2030, which is a global movement aimed at building stronger health systems in order to reach universal health coverage. And another important point is that still social policies should aim to be governed through the 3 R's, which are redistribution, regulations, and rights for the populations. So now I would like to introduce you to the different speakers of this panel. We first have Dr. Karel Gieseling, who is working at the Belgian Development Agency. He's also the president of the Because Health platform and the current president of FESTME. And we have 3 honorable speakers today. First start by Dr. Christine Kirunga Tashobya, who comes back to her home in a way because she studied here in Antwerp and in Louvain for her PhD, and she also holds a number of diplomas from the London School of Hygiene and Tropical Medicine and Makerere University in Kampala. She's a health system specialist, currently engaged in a postdoctoral fellow with the project called SPEED, which stands for Support Policy Engagement for Evidence-Based Decisions for Universal Health Coverage. It is funded by the European Union at the Makerere University. She has accumulated extensive experience in health policy, financing, and system management over almost 3 decades, working in Uganda and beyond. We also have Dr. Jan Paehler, who is a medical doctor with a doctorate in cardiology and an MSc in health system management. He spent 5 years in Ghana, first in a public hospital, and then overseeing a USAID project. He worked at the Advisory Council on Development in the German healthcare system, which is the major think tank on health system advising to support the German Ministry of Health. And then he joined the European Union, where he first managed research grant on public health and health systems in the Commission's DG for research. And now he leads the health system in the health team in the European Commission's DG for international cooperation and development. And finally, last but not least, of course, we have Remco van der Paas, who is a medical doctor and global health scholar. His PhD research focused on global health governance of the health workforce. He held various positions in civil society organizations like WEMOS and Médecins du Monde, and he's a board member of the Medicus Mundi International Network. He also teaches at universities and in international courses on global health governance, diplomacy, and policy coherence for health, with a special attention on health workforce development and migration, health system strengthening, social protection, the health impacts of globalization, and health equity. He's now a research fellow here at the Institute of Tropical Medicine in Antwerp, and he is also the academic coordinator at the Maastricht Center for Global Health, set up recently at the Maastricht University. So how are we going to proceed? We are going to lead the debate around two major questions, and then the moderator, Dr. Gieselink, will ask for further questions. The first question will be the following. What is your viewpoint on health cooperation the way it is today? And the second question will be, what is the way forward? But please, that questions and answers with such a large audience are not allowed, but you directly, I mean. But if you want, you can, if you have other questions, you can send them on Twitter. Mind you, there is a small typo on the slide, which we didn't have the time to correct. Of course, it is hashtag ECTMIH2017. So if you wish to send questions or your own thoughts, you can send it to Twitter. And either we will have time to discuss it now, or if you want, you can participate in another session on the international cooperation this afternoon. But first, I will give the floor to Dr. Gieselink and the panelists to discuss the first question. Thank you.
Thank you. Thank you, Elizabeth, for depicting and setting the scene in this Elizabeth Hall. Quite fitting. So, welcome, Christine, welcome, Jan, and welcome, Remco, and also welcome to you all. So we have this 3 quarters to have a chat around health cooperation in the context Elizabeth just depicted. 3 different voices, 3 different perspectives. So, and the first set of questions will be centered around the actual view. What is your viewpoint on health cooperation the way it is now? Health cooperation is based on one of the largest social hypotheses that of our times, that countries and organizations can collaborate with other countries to reduce poverty and inequity and contribute to prosperity. This largely has been tested, but should be continuously critically evaluated. And in 2016, MMI, Medicus Mundi International, has worked on a discussion paper on health cooperation, its relevance, its legitimacy and effectiveness as a contribution to achieving universal access to health. So, Remco, let me start with you, since you are one of the co-authors of this discussion paper. What is the paper about, and where does health cooperation stand now in your view?
Okay, thank you very much. So within Medicus Mundi International, which is a network of NGOs and academia, we reflected that cooperation for health was not working as it should be, or we were a little bit frustrated in the sense seeing that we were not actually closing gaps as we would have thought several years ago, even going back to Alma Ata and in relation to the debate now on universal health coverage, etc. So we wrote that discussion paper as an input for debate, also for mainly NGOs and academia to position themselves in this regard. So my analysis, it's a personal analysis, which is a bit also challenging the development discourse as a way to help it being pushed further. We have to look a little bit backward to understand where health cooperation is now. In a sense, health cooperation and aid is coming from the times after World War II, times of decolonization, with the idea that there should be a stable world order based on principles of free trade, economic growth and liberal democracies. And as a kind of a global social contract, there was also foreseen that there was a transfer of resources for social goods. It is official development assistance. Countries pledged to provide 0.7% of their GDP for that. But when we look back, that never really materialized, especially during austerity times, economic restructuring packages, trade negotiations in the 80s and 90s. Aid has never had that transformative role as it was foreseen to have. It saved lives, but it also somehow maintained the status quo of a very unfair economic and trade regime. Now in the 90s, after the fall of the Berlin Wall, we saw an opening that not only member states, but also NGOs, academia, philanthropy, commercial actors had a larger role in global health. There was the HIV/AIDS epidemic. It opened up the need to really cooperate, to work together to address this. And it started a phase what is being known as the global health revolution. Global health became more important also in foreign policy, for foreign policy issues. And this was also related to recognizing that health is important for economic growth. Healthcare is the third largest economic sector worldwide and could contribute as well to economic benefits of countries. And later, especially after 9/11, that health is very much linked also to peace and stability and security. So in the second part, or after 2011, the whole development, diplomacy and defense nexus became more closely interlinked. So in relation to health and health cooperation, we saw that the MDGs rallied a lot of funding for quite targeted goals. There has been considerable improvement in the reduction of child mortality, maternal mortality, addressing the HIV/AIDS epidemic, etc. But at the same time, there has always been a debate about more the systemic nature and the sustainability to maintain these gains. And this is where health system strengthening and that debate also started, that there needs to be finance in relation to the workforce, social protection for health, universal health coverage, how to do that. And several actors, global health initiatives, they start to cooperate on this. They start to align. There was the Paris 8 agenda on aid effectiveness, on alignment, country priorities, etc. Now that agenda is still very valid, but we see over the last 5 years, after the economic crisis, and in a world that is somewhat unstable, that countries, they retain a little bit and they go back to their own policy objectives. So there is in a sense I wouldn't call it a crisis, but countries focus on their domestic policies first rather than investing in the multilateral system and in international cooperation, which leads also to, when they invest, for instance in WHO or in a bilateral program, that they want to have control over it. And this is where then values come in play, and what matters for countries to invest in this international cooperation. So we see now that there is several values intermingling and defining the basis for development cooperation. And those values are security, in the sense of addressing epidemics. It's about trade and investment and ensuring economic growth between countries, enhancing trade. There can be public health goals. There's a global burden of disease and we need to address this, including the NCD agenda. There might be even, from a human rights perspective, the need to cooperate, and then we talk more about, for instance, sexual and reproductive rights. And one can also say that there's a need to invest in the global system, in global public goods, in the evidence. For instance, the WHO and UNICEF, they need to have finance to make it function. But we see that slowly over time, this global health revolution has stagnated, and that there is now, so to say, a kind of a tension between whether sustainable development and health is still on the priority of the agendas of countries. And that recognition is there here in the West, I think more and more also in other regions in the world, known as global health diplomacy, and that there needs to be a kind of debate about these strategies. The EU has done that. There's an EU role in global health, where health, development cooperation, research objectives, they come together. There's a whole debate now going on also on health as being a crucial part of G7 and G20 deliberations. There's countries that have developed a global health strategy. So health cooperation has become closer aligned to these wider policy objectives. Now, we will discuss afterwards where to go from there, but with funding for international health, global health has been leveled more or less. We see also philanthropy taking a larger role of this. Of course, especially the Gates Foundation has a considerable share of this, but then the question is, who benefits from these investments? What is the political economy of these arrangements? Similar, there's a debate about the humanitarian space. Does it still exist? There's also a blending there between humanitarian development and defense objectives, which also brings development actors at risk. We see a higher rate of attacks against healthcare workers, etc. So there are some crucial issues that we need to reflect on as actors, where to go and to really make sure that the Sustainable Development Agenda and its partnerships move forward, and that we don't get backtracked by other issues. Thank you.
Okay, thank you, Remco. Christine, being a Ugandan citizen and researcher, what is the perception of health cooperation from your perspective?
Thank you, Karel, and I would like to acknowledge and appreciate the organizers for asking me to be part of this. Well, I'll talk from the perspective of a low-income country, and I'm specific low-income country, not low and middle income, but more low-income country, because I think that is important. But I think I would also like to talk from the perspective of aid for development. I'm sort of making an assumption, a bit of a naive assumption, but looking at our agenda here, doing development differently. So I'm focusing much more on aid intended for development. And first of all, to give the perspective of how big this aid can be in a context like Uganda. In Uganda, when you look at the total expenditure on health, development partner support provides about 30%. In HIV/AIDS, it provides closer to 70%. So these are huge amounts of money in absolute terms, but particularly in relative terms. So this is the kind of animal we need to face and consider what it means in a developing country, in a low-income country like Uganda. That having this cooperation, having this aid work efficiently and effectively is very important to the people of these countries. And then also briefly on the evolution of health cooperation over the last 30 years. In the 80s and 90s, aid was seen to be very inefficient and very inequitable with standalone vertical programs. But into the late 90s and early 2000s, as both Elizabeth and Remco have pointed out, there was this realization and the need or the efforts to try and make some improvements in the way health cooperation was working. And so we had the swaps and the Paris Declaration, and a number of positive things came out of that. There was focus on joint programming, trying to look at sectors, the health sector, as in a comprehensive and coherent manner. There were attempts to look at the financing programs and even attempts to finance through government systems. There were also serious attempts made at joint monitoring. And these have created a certain momentum. However, in the more recent times, and Remco did point this out, with the global health initiatives also coming on board as big players, these brought in a lot of money, but also the changes that were happening in the donor countries, there was felt a need to look again at what was happening. So you had on the donor side some issues of austerity, issues of relooking at values and what the intention of aid was. But there were also things on the beneficiary country side. Many donors felt that there wasn't enough accountability. There were challenges with governance broadly. Also the effectiveness of aid with sometimes perceived inadequate results from the aid that was being provided. So a number of these, again, led to the going slow, as it were, of some of the efforts that had been made to try and improve the way aid works, or health cooperation, and many of the countries, of the donor countries, sort of retraced their steps and went back to previous modalities of health cooperation. And what has this led to? I think one of the big challenges we have now, given what I mentioned at the beginning, the kind of how much aid means in a country, in a health system like in Uganda, one big problem is non-coherent health systems. So you have aid or donor money, actually more than government money in the health system. I talked about 30%. In many cases, public funds are about 20%, and 50%. I'm using Ugandan figures. There's a bit of variation in other countries, but it gives a sense. So it is practically impossible in such a setup to actually have a coherent, robust, resilient health system, especially if the 30% from the development partners or donors is not being used together with the public funds in a coherent manner. The second point I would like to point out, and maybe still on the health systems, and Remco did point out some of these things. So the quality of care, the efficiency and the equity of the system is very wanting. For example, in Uganda, over the last 10 years or so, there's hardly been any increment in health workers' salaries. And the cost of living has gone up more than twice. So this is the kind of health system that you have. You will have funding from development partners for programming, say, for HIV, AIDS, or malaria, but the base health system is very ineffectual. The second point I wanted to mention is limited ownership. So these huge resources do come in from partners, but the government does not have a lot to say about them. The government will sit with stakeholders and put together the country program, but it is not being funded by these funds that come in. The prioritization indicated in the policy documents is not the prioritization of the funding entities. So there is very limited ownership within government circles, whether it's at the national level or the sectoral level or the local government level in regard to development partner funding. Most of the time the sense is they'll bring in the money, they want to do this, the most we can do is work with them to do that. So I think for now, those are the points I thought I would lay out. Thank you.
Okay, thank you, Christine. And Jan, working at Europe Aid, what is your viewpoint on health cooperation as it is now?
Yeah, thanks a lot also for inviting the European Commission to this debate, but also to present all the EU-funded projects in sessions or in stands downstairs. And if we look at how health cooperation functions today, I think we need to look back at the golden decade, the first decade of this century, where health was really a donor darling, really present, a priority for everybody involved in cooperation. And I think rightly so. And I think also the MDGs have really helped crystallize, as Remco said, the focus on health. 3 of the 8 MDGs were focused directly on health. But that has had some implications, because there were only a few conditions, a few diseases that were focused on, and that may have been part of the attractiveness, because that's people would understand and would rally behind. And the other big success factor was, of course, the creation of these funding pots that are particularly related or to the MDGs, so the Global Fund to fight AIDS, TB, and malaria, and the Gavi Vaccine Alliance. And they're spending between them $5.5 billion every year, have really also helped crystallize the focus on these conditions and helped to the impressive progress that are achieved by countries on the 3 diseases, but also on child mortality that has been quite successful. But now that the low-hanging fruits have been picked and the quick wins have been reaped, so we need to focus what's the impact for the longer term, and how can we use the benefits of this vertical approach to move to more integrated health systems approach to have an impact beyond the 3 diseases, beyond child and maternal health. And that is, I think, the challenge for the future. And it has also been complicated by the fact, because the global initiatives have been so successful or attractive to donors because they could show impact on a specific question. They were good at reporting. So more and more donors, including EU member states, have while not reducing the overall commitments to health, have channeled more and more health funds through the global initiatives and much less through bilateral programs. And this, and at the same time, because of the success of these initiatives, there have been many more initiatives proposed collecting money, and that goes beyond health to other social sectors as well. Which has made it then very difficult for countries to coordinate with these massive funding agencies, but also the myriad of new players who fund activities in a country. So, and these initiatives usually come with a business model that they don't have a country presence. They sit in Geneva, New York, Washington, or elsewhere, and rely on in-country partnerships, country ownership for a successful implementation of their programs. And this is more difficult to do if the partners, the member states, the EU, have less programs on the ground, expertise to help the country coordinate all these large donors. But of course there is also the opportunity by focusing funding through a few initiatives. There is scope for governments to press them more or collectively press them more on harmonization, alignment with country processes and budgeting and ultimately country ownership. But it needs to be play together. The danger is still this distortion that if such vast amounts of money come into the country and they're focused only on one condition or one disease, it is difficult then to have a more integrated planning and management of health. But also there's the political economy, and one good example is the discussion between HIV treatment and prevention, and with scarcity of resources, and it's always a question of life and death. That decision needs to be taken by the appropriate country mechanisms, the government, the civil society, the society as a whole. But it is difficult if then the financing comes from one entity and the UN organizations are saying, well, you have to do treatment we have these global guidelines that apply to everybody. Everybody needs to be treated, but there needs to be prevention as well. So we need to be clear who takes these crucial prioritization decisions and who can be ultimately held accountable. And I think that is a discussion that is still ongoing, and it's not clear who should take responsibility. And so for the EU, We have, like many member states, also have concentrated our aid to various sectors in each country in dialogue with the countries that we collaborate with. And that meant, while the overall funding for global health has not decreased, but the number of countries receiving EU funds for health collaboration have decreased from 42 to now 17. And these programs are usually focused on broader health systems strengthening, but is then also complemented by EU contributions to the global initiatives, notably the Global Fund and Gavi, where the Commission has focused on strong governance, representation on the board, precisely to hold these organizations to account globally on their commitments, but particularly at country level, so that they do exploit the partnerships that they rely on. And then, of course, the EU should be more the sum of its pieces, so we try to collaborate with our member states to coordinate that in each country that we collaborate with, either the EU or one of the member states takes the lead in ensuring that health programs collectively have an impact. And we do have also formal mechanisms like the joint programming that we're rolling out, where we invite member states to rally around a joint EU plan that is discussed as one with the government and that member states can then support. Then the policy dialogue in the countries need to become to a broader level. So we need to talk about domestic resource mobilization, equity, human rights, and good governance. So that is not related to the health sector alone. While in the health sector, as Christina has said, the aid effectiveness is crucial, looking at harmonization, alignment, managing for results, and there the International Health Partnership is supported, and that will now be moving on to the UHC 2030 partnership for aid effectiveness, not only coordinating at country but also at global level. And lastly, like Remco said, we need to strengthen global governance, and the WHO is the lead agency in that respect, and the EU is supporting those and tries to promote global health issues in the G7 and 20 context where we are represented.
Okay, thank you, Jan. I would like to come back, Christine, on what you said on ownership. You mentioned the name, and looking a bit now on the way forward, going to the second question on the way forward. I remember the Dakar Declaration in 2013, where a lot of the people from the district level came together and explicitly mentioned in the final statement the importance of more autonomy, more empowerment of the local communities to take health in their own hands and claiming their health rights. What do you think of that statement? Is that realistic? Is this possible, or is it just a fad?
I think it's possible, but it has to be part of a functional national health system. I think it's not really feasible to look at a functional local health system in a completely dysfunctional national health system. And in terms of sustainable development goals and universal health coverage, there's the need for particular involvement of the government, ownership of these by the government. So before you can go to the local health system, it can't function in a vacuum. It cannot function in a vacuum. So I do believe very strongly about the centrality of government in any useful health cooperation arrangement. To build the health system, to provide ownership, and to give guidance, not only for any work you do today or any system development today, but also for the medium and for the long term. And I think that's where there is still quite a bit of challenge. as Jan has been talking about the EU and working with WHO and with the UHC 2030, there are very good intentions there, but in the last 5 years, not very tangible kind of things. I was one of those who worked with the SWAP in Uganda and the IHP Plus and the UHC 2030. Currently, it does not do much in tangible terms. So it's something that the EU and the member states and other development partners really have to look at, because I think it's not working at the moment. One of the things I think, some of the specific things in working with these national governments is long-term engagement. And I like what Jan has said about the EU, for example, moving from working in many countries to fewer countries. I think that can build relationships that can actually work better when you have the development partner appreciating the issues in country. Again, no size fits all. And that's quite common in health cooperation. Cut and paste from different contexts. It has worked in Rwanda, so Uganda should do it. Most of the time,